Well, hello, this is Dr. Philip May. I will be speaking with you today about longitudinal graphic analysis, which is a tool designed to demonstrate efficacy of treatment of chronic conditions encountered in patients with disabilities. Why are we having this talk? In the year 2000, Matson and others concluded in his 10-year review, which was published in Research in Developmental Disabilities in the year 2000, Matson stated that given the overall paucity of evidence, the continued inappropriate use of psychotropic medication in persons with mental retardation, that's his term, extends beyond a question of ethics and becomes an urgent moral dilemma. So what has changed in the past decade? We no longer use the term mental retardation. We now use the term intellectual disability, which everyone feels is the much preferred term. However, the inappropriate use of psychotropic medication continues. To give you a little background, first, people with chronic disabilities, especially those with medically complex developmental disabilities, often have many associated and interrelated chronic health conditions. Examples include chronic cognitive dysfunction, chronic motor dysfunction, severe maladaptive behaviors, and recurrent seizures. These conditions then may lead to numerous health consequences such as injury from falls, recurrent aspiration pneumonia, severe gastrointestinal problems, osteoporosis, and fractures are all frequently seen in this population. Treatment of these conditions are often ineffective and lead to polypharmacy and increased risk for drug toxicity. Longitudinal graphic analysis, which we call LGA, is designed to demonstrate whether any given treatment is effective or not, and therefore provides objective feedback to the treating physician, which would indicate whether a treatment should be continued or discontinued. LGA is especially valuable for determination of efficacy of psychotropic medication, and that will be our focus on today's talk, will be on psychotropic medication. Now, what exactly is LGA? Longitudinal graphic analysis is an ongoing process of graphic correlation of the frequency of a specific symptom with the dose of a specific treatment designed to affect the frequency and/or severity of that symptom. The process of LGA consists of 5 steps. The first step is precise definition of a specific target symptom that will be counted. For example, assaultive behavior or self-injurious behavior, seizure, even constipation. Any symptom could be counted. But as I mentioned, today's talk will be focused on the behavioral issues. In step 2, we record a monthly baseline frequency of the target symptom or condition on an Excel graph for at least 3 months. These would be the episodes per month that will be recorded. This will be known as the treatment efficacy graph, or TEG. For example, seizures per month, episodes of aggression per month, or even bowel movements per month could all be counted. In step 3, there's the formulation of a working hypothesis or diagnosis as to what is believed might be responsible for the condition that will be treated. For example, if there is a self-injurious behavior or episodes of impulsive aggression, a diagnosis such as atypical psychosis or bipolar, etc., could be made. Idiopathic epilepsy to explain the seizures. There can be also seizures from drug toxicity and electrolyte imbalance, but that would be determined during the baseline period. Or if you're talking about the problem of constipation, bowel dysmotility, may be your diagnosis. So depending upon the symptom or condition, you should have a diagnosis which justifies the treatment that you will select. In step 4 is the actual selection and implementation of an intervention or treatment based on the diagnostic formulation established in step 3. For example, if it's a behavior problem, Zyprexa. If it's a seizure problem, perhaps Depakote. Or if it's a constipation problem, Miralax may be your intervention or treatment. Alternatively, since we're talking about behavior, if you determine that the behavior may be related to the environment that the person is in, environmental change may be your intervention. Or an exercise program may be your intervention. So this is a general formulation here that we're talking about, and then you pick the treatment which is most appropriate. In step 5, you continue to collect and graph monthly frequency data. This is after your treatment is started, and then you adjust your diagnosis and or treatment plan based on the analysis of the data as it correlates with the treatment interventions. So here's a summary of the 5 steps. First, define the symptom to be treated. Then you establish a baseline frequency. Next, you establish a working diagnosis to justify the treatment. Then you actually select and implement the treatment. And then lastly, you continue to monitor, record, and adjust based on the diagnosis and or treatment. And that is a summary of the 5 steps of longitudinal graphic analysis. Now I'm going to give you some examples. Okay, here's an example of using longitudinal graphic analysis to determine the treatment efficacy for vomiting. This is a person who's having about 15 episodes of vomiting per month. And this was not severe episodes or small kind of regurgitations, but nonetheless it was a disturbing symptom. And following the steps of LGA, we established a baseline frequency of 15 times per month. And our working diagnosis in step 3 was that this was related to perhaps constipation, poor bowel motility, and so we selected a treatment, initially Miralax, a laxative, in June of 2005, and you can see that the laxative did have an effect on the frequency of the bowel movements, which went up from about 10 times per month, in the red line there, up to as high as 30 times per month. In October of 2005, so that would average one per day. And the frequency of vomiting did go down a bit with better bowel movements, but it was still there, still kind of little regurgitations. This was not, severe projectile vomiting, anything like that. It was not an emergency situation. But we added Reglan, a prokinetic agent, to improve bowel motility and to increase gastric emptying in September of 2005, and that did seem to improve the vomiting episode as well. And we added Prevacid in October of 2005. I'm not sure whether that affected the vomiting so much, but if there were some regurgitation, it would cut down on the esophagitis. So that was our regimen: Prevacid, Reglan, and Miralax, and this did seem to eliminate the symptom. Whether these three medications will need to be continued indefinitely. It's not really clear. We'll continue to monitor and reevaluate and adjust the treatment and the diagnosis as we go. So that's an example of using LGA to determine treatment efficacy with Miralax, Prevacid, and Reglan on the episodes of vomiting. Okay, let's talk about seizures. I have a couple of examples, starting with this particular slide. This is a person who has seizures at about 5 to 10 times per month. Is on Tegretol. The Tegretol, we don't know really whether the Tegretol has provided any benefit or not. We don't have a baseline, before Tegretol was started. But you can see as of May 2000, we did a switchover of adding Depakote and removing Tegretol, Depakote-Tegretol switchover. And you can see the Depakote really did seem to decrease the frequency of the seizures. However, there were still some seizures, and we then added Lamictal up to 100 and then up to 150 milligrams per day of Lamictal. It's not really clear that the Lamictal really provided benefit. So in May of 2000, we added Dilantin up to 200 milligrams per day. But the seizures really did come down. It seemed like the Dilantin really added additional benefit. So following the steps of longitudinal graphic analysis, we will continue to monitor and perhaps reduce and eliminate the Lamictal to see if that really needs to be present. Practically speaking, we would probably see him being left on the Lamictal, the Dilantin, the Depakote, because he was doing very well. But the LGA, if you look at it carefully, if you look at the graph carefully, certainly when he was on 100 milligrams per day of Lamictal, there was no benefit, and up to 150, at least for a month there, they did not seem to improve the frequency of the seizures. So I think that maybe the Depakote-Dilantin combination may be the best way to go. Okay, here's another example of using LGA to determine or monitor treatment efficacy for seizures. And this is a person who's having 30 to 40 seizures per month when we started. And there's a natural, fluctuation. It came down, with no change of treatment. He was on Depakote and Tegretol originally, and for some reason it decreased to more like 5 to 10 times per month in 1999, 2000, up to 2002, then began to increase back up as in July of 03 to January of 04, and Lamictal, was added, and the addition of Lamictal seemed to really improve the seizures. The seizures went down to only 0 to 2 or 3 times, per month by January of 2007. We tried to reduce the Depakote, and that seemed to increase the frequency of the seizures. In July of 2008, you can see there's a little spike there using Keppra, which did not seem to have any benefit. We didn't really give a fair trial with the Keppra, but didn't seem to really do anything. At the end, we tried some Banzel, which is a new newer drug, and that really hasn't really been on that long enough to evaluate. But after a few months, that did not seem to have much of an effect at all. It seemed like the Lamictal added some benefit. Whether and it looked like when we tried to decrease the Depakote, you can see the seizure frequency went up. So that is some evidence that the Depakote was efficacious. And then we took him off the Tegretol completely after the Lamictal was started. The Tegretol was discontinued by July of 2005. You can see that in the yellow line, and this did not cause the seizure frequency to go up. So just looking at that briefly, it looks like the Lamictal and the Depakote combination might be the best thing for this particular individual. These will be clinical examples using LGA to establish the efficacy of treatment of destructive behavior. And this could be self-injurious behavior, or it could be aggressive behavior or property destruction. But I'm going to be talking about a case of self-injurious behavior. Okay, let's take a look at this graph. This is a person who is demonstrating self-injurious behavior, and the graph starts in January of 2008. And if you'll see the very first entry there, the SIB, self-injurious behavior, in blue, the frequency per month is 30. The next month, in February of 2008, it goes down to 20. And then next back up to 35. So there's an up and down of the behavior, which is fairly typical, that the frequency can vary month to month based on a number of factors. These behaviors are complex, and many conditions can influence the frequency of these behaviors. So you can see there's a baseline period from January of 2008 until July of 2008. Then in August, the treatment with Zyprexa has begun. That's shown in the red squares, red rectangles. The red line there is the Zyprexa treatment, and it starts with 5 milligrams, and the dose increases up to 20 milligrams. Now, I don't have any details here about the thinking of the previous steps. We're starting with treatment here, but before the treatment is started, the symptom of self-injurious behavior needs to be carefully defined. Are you talking about head hitting, face slapping, wrist biting? So this has to be defined in terms of severity as well, because it's the responsibility of the prescriber to make sure that the staff or family that is collecting the data for you is collecting what you want them to collect, and something that is severe enough to warrant the medication of Zyprexa, which has a lot of side effects. So in step one, you define the symptom carefully so people know what to count. And then in step two, you can see we're establishing the baseline frequency here, which varies from roughly 30 times a month to 10 times per month. So there's a big variation. You can see that if you started the medication, say in May of 2008, when the frequency was 30, in June of 2008, it had decreased to 10. You would think that that was from the Zyprexa, but because you have a long enough baseline, you can determine that it was not the Zyprexa. It was a natural fluctuation of the behavior from month to month. Now, after you have increased the Zyprexa up to a therapeutic dose, you can see that the behavior has come down. And this is evidence, although not absolute 100% proof, but it is strong evidence that the Zyprexa has led to that change. So that would be support for the appropriate use of Zyprexa. Now, as time goes on, we're going to go beyond May 2009 now on another graph which follows up. Okay, in this graph, starting in June 2009, you can see that the person, this is the same person, just a later time period, is on the Zyprexa, 20 milligrams per day on the red line. And then the physician decides that even though there's an improvement, that maybe we could do better. So another psychotropic drug was used, which is Depakote. Depakote is also a seizure drug, but it also can affect behavior, especially conditions like bipolar. So the Depakote was increased up to 1,500 milligrams per day and remained on that. And you can see the behavior continues to fluctuate, but it does not improve. That still the best that has been done is around between 5 and 10 episodes per month of self-injurious behavior. So this looks like the Depakote was ineffective. All right, let's go on past November 2010. What is happening now? Okay, the prescriber decided that whereas the Depakote was not effective, maybe Paxil would work. So in March 2011, Paxil was begun and increased up to 30 milligrams per day. The Depakote was continued and the Zyprexa was continued. Now, just looking at this graph, this appears that the behavior is worse with the Paxil. The effects of the Zyprexa and Depakote were determined in graphs 1 and 2. Otherwise, you would need to taper the Zyprexa and the Depakote in order to determine the efficacy. So this underscores the point that it is very important to have previous data, longitudinal. This is why it's called longitudinal graphic analysis. So the previous graphs are very important to have, or the data, at least on the previous graphs, are very important to have, so that you know that, first of all, the Zyprexa was effective or had been effective, because he used to have 25, 30 times per month, and the 5 to 10 times per month is an improvement, but it's not perfection. So, and we know now that the Depakote was ineffective, but you can't tell it from looking at this particular graph. You would need the previous graph. This graph shows you the Paxil was ineffective. So it would be necessary for the physician to taper the Depakote and the Paxil. Otherwise, if you continue them, it would be an inappropriate use of medication, subjecting the person to needless potential toxicity. Now, this graph is developed by another group, Kalashnik, Sovner, Walsh, and Kastner, who are all experts in this field, and they do the same thing, the same process. I don't think they call it longitudinal graphic analysis, but this was taken from one of their talks years ago, and they use a little different format, but the point is that it's demonstrating the same type of problem, that this group of experts is well aware that many people are on inappropriate drugs that are ineffective, and in their lecture they're pointing out that in this case And this is not a real case. This is just showing a principle that they have seen demonstrated in real cases, showing in February behavior going up, and drug number 1 is started. It doesn't work, so they add another drug. That doesn't work. They add a third drug. That doesn't work. So this is how people end up on polypharmacy. Instead of tapering off drug number 1 before you try drug number 2, the drugs tend to be added and never stopped. So this is the problem. This is how people end up on inappropriate treatment, and these experts certainly are aware of that, and they're trying to point this principle out with this slide. So once again, just to review the summary of the 5 steps. Step 1, you define the symptom. In 2, you establish the baseline frequency. In 3, you establish a working diagnosis to justify the treatment. In step 4, you select a treatment or intervention. And in step 5, you continue to monitor and record and adjust the diagnosis and or treatment based on the data that you have collected. So in conclusion, the advantage of longitudinal graphic analysis is that by being able to document and provide feedback to the prescriber, as well as to the administrations that are ultimately responsible for the quality of care provided to these individuals with developmental disabilities, LGA can help to clarify whether treatment is ineffective, thus unnecessary and inappropriate. Clinicians who utilize LGA in their practices report a reduction in drug use because of that feedback provided by the treatment efficacy graph produced by LGA. That concludes my talk. Thank you very much for listening. If you need to get in touch with me or would like further information about LGA, you can email me at ifcd.pmay@gmail.com. You can visit our website for the International Foundation for Chronic Disabilities at www.chronicdisabilities.org. Or if you would like to view other PowerPoint presentations on health conditions encountered in adults with developmental disabilities, you can go to our affiliated website at www.youtube.com/user/PhilipMay123. Thanks again, and bye-bye.